I am Dr. Dhiman Kahli. I am Director Intervention Birla Heart Research Center, and I was the ex-chairman of National Intervention Council, Cardiological Society of India. Today we are going to talk about hypertrophic cardiomyopathy, both non-obstructive and obstructive. Obstructive cases occur in 2/3 of all the patients of hypertrophic cardiomyopathy, and in another 1/3 it is non-obstructive, means there is no obstruction inside the left-sided cavity or left ventricular cavity. So that is the basic difference. But what occurs in hypertrophic cardiomyopathy, we should know about it, that the heart muscle, you can see that this is the heart muscle. This heart muscle gets thickened. You can see the heart muscle. The normal thickness is 0.8 or 0.9 centimeter. Up to 0.11 centimeter, means 11 millimeter, we call it as normal, upper normal. But if it goes above 11, then we call that there is some amount of hypertrophy. In hypertrophic cardiomyopathy, the heart muscle gets very much thickened. Now what is the problem? Problem is that you can see the left ventricle, that it is asymmetrically involved. Definition wise, if the thickness is more than 15 millimeter, we call it as hypertrophic cardiomyopathy. In obstructive variety of hypertrophic cardiomyopathy, there is obstruction when the heart muscle pumps. The blood doesn't go well, and there is some obstruction at the outflow tract or at the apex or at the mid cavity because of the hypertrophied heart muscle. This is called as obstructive hypertrophic cardiomyopathy. Now you don't worry, because the yearly fatality from this ailment is only 1 to 2%. But people have the idea that, oh, I am suffering from very severe disease, because the patients are often very symptomatic despite adequate medical treatment. But the prognosis doesn't depend on the symptomatology. But okay, if some patients are severely symptomatic, that needs some more therapy, means surgical septal reduction therapy. Now septal reduction therapy can be of two varieties. One is just reduction of the septum, means myectomy. We cut out the muscle and take some portion of it. Sometimes they also repair the mitral valve. Rarely they can change the mitral valve also, means mitral valve replacement. So this is surgical therapy. Majority of the patients go for surgical therapy in the younger group. It's a corollary, you know. In the younger group, normally we go for stenting and bypass surgery for little aged patient. But here it's opposite. For younger patients, we go for septal alcohol ablation. What is it? You can see the LED. This is the LED. These are the septal branches. Now the branch which is supplying the maximum hypertrophied portion, thickened portion of the septum, is occluded by putting the catheter here and by injecting some alcohol inside it, 1 ml of alcohol like that, and the artery gets occluded, and artificially we produce a heart attack of the septum, so that the thick heart attack muscle becomes thinned. So this is known as alcoholic septal ablation. The other variety I talked about is surgical myectomy or mitral valve repair or mitral valve repair and mitral valve replacement surgery. So these are the different septal reduction therapy, SRT as it is called. SRT includes surgery as well as invasive wise, that is we cardiologists do the septal ablation by injecting alcohol. So this is in short the therapy for the disease. But still, you know, some patients are very symptomatic. Normally we give beta blockers, we give some non-dihydropyridine calcium channel blockers like diltiazem or verapamil. We give a combination of the two, and if some patients are very severely symptomatic despite doses of beta blocker and calcium blockers given a very adequate dosage or as tolerated by the patient in a maximum possible dosage, the patient is still symptomatic. I presented the data which was presented also in the American College of Cardiology and American Heart Association and also in the ESC meeting, that there is a new drug called as mavacamten. This is a very new drug which is a myosin inhibitor, and what it does, it causes inhibition of the actin-myosin complex. So this is the new drug which has come. 16 weeks results are over, and it has shown improvement in the quality of life, reduction in the size of the muscle thickness, which is phenomenal, and reduction in the gradient. Suppose the gradient is 80 millimeter across the left ventricular outflow tract with the normal drug therapy, with drug therapy which has been conventional, because this drug has not yet come to the market. Neither in US it is found, nor in Europe, and also in our country it is not available. So it is not marketed. It is still in the experimental stages, but phase 3 trials has been done. Phase 2 trial is already completed, and now there is one trial known as MAVA-XR trial, which is MAVA-LTE trial, which is going on for 5 years. It will be completed after 5 years, and till the results come, I think the drug shall not be marketed, but maybe with the interim results the drug may come to the market sooner, and this shows some promise, and this has shown to increase the quality of life. The symptoms are severely reduced. Regarding the mortality data, there is no data as yet because it is only a 16 weeks data available, but recently in American Heart Association meeting they presented the 6 months data, which is also very encouraging, the HCM, Valor HCM trial data, and let us wait for the Explorer LTE data. So these are the 3-4 trials going on, and Maverick trial is a phase 2 trial which has also very shown promising result with this drug, and the dose is 2.5 milligram to start with. After 2 weeks we can increase it to 5 milligrams, and after 1 month we can go to 10 milligrams, and it is a well tolerated drug. It does not cause much of low blood pressure or side effects, but okay, all the drugs has got little side effects, so that must be with mavacamten also. But mavacamten has come to the armamentarium of the cardiologist in a very big way, and hopefully this will occupy a big portion in the treatment of this hypertrophic cardiomyopathy patient. But again I tell, if you have severe symptoms, or many patients complain, sir, always I have some heaviness in the chest, central chest, like the angina. So they are very apprehensive, they are very anxious. I allay them. When they listen, no, the mortality, the fatality is very low, 1% per year, they get much allayed. Half of their symptoms subsided that. Rest goes away with the drugs. So don't be anxious, don't be apprehensive, don't be fearful about this disease entity. We have got very good treatment for this disease, hypertrophic obstructive cardiomyopathy. If drugs do not do everything, we have septal ablation done by cardiologists, and also the septal myectomy done by our surgeon friends. Thank you very much for your kind attention.